So these are the commonest vitamin A deficiencies that we can see. So what you're seeing here is the bite-out spot. The bite-out spot is characteristically present in the interpalpebral fissure or in the palpebral aperture, as we call it, the central area that is visible. So this has a foamy appearance. It has a foamy and keratinized appearance. Foamy and keratinized appearance. And this foamy and keratinized appearance is probably because of saprophytic bacilli that can produce this, when they undergo metabolysis, they produce this appearance. And basically the eye is extremely dry. There is a characteristic dry eye. As you can see, this is a lustreless cornea. You can hardly make out the presence of a tear film here. So this dry eye is usually very, very symptomatic for the patient in the extreme stages, where they can have redness, they can have grittiness, and they can have congestion. So whenever a patient presents to you with dry eye, especially if there are risk factors, then we need to think of vitamin A deficiency. So what are these risk factors that we're going to think of? One of the most common things is a dietary deficiency. This dietary deficiency can arise because of protein energy malnutrition. Defective absorption can also play a part. Defective absorption particularly occurs in diseases such as biliary cirrhosis or cystic fibrosis, or it can also occur in chronic alcoholism. So these are all features where there can be total absorption of vitamin A. And chronic alcoholism is not only a vitamin A disorder. There are also other vitamins that are poorly absorbed in chronic alcoholism. So we need to know that it can either be defective dietary supplementation or defective absorption. So any of these factors can cause a vitamin A deficiency. And here also you can see that the patient has some amount of, there is basically a lustreless eye. You can see that there is a deficiency of tear film. The normal tear film meniscus is present here. So this is the area where we detect the tear film meniscus. And differential diagnosis of nyctalopia is very important. When I say nyctalopia, I am talking about night blindness. So nyctalopia classically is present in patients with vitamin A deficiency. In the extreme stages of vitamin A deficiency, you can have nyctalopia. You can have nyctalopia and retinitis pigmentosa. These are the most common disorders, apart from which you can also have nyctalopia in patients who have, any other changes in the retina that affects the photoreceptors. You can have in patients who have, conditions such as advanced myopia or, all refractive errors such as in their advanced stages. All this can cause nyctalopia. So the WHO classification of vitamin A deficiency has given night blindness as one of the first symptoms. It has also classified it into 1A, 1B, 2, 3A, 3B, and S and F. So each of this stands for a specific term. When we say bite-out spots, we're talking about bite-out spots that I just showed you on the previous slide. The foamy appearance, they appear as foamy, and they also have a keratinized appearance, and usually they're present in the interpalpebral aperture. When you say corneal xerosis, you're talking about a dry corneal appearance. 3A is corneal ulceration, which is less than 1/3 area of the cornea. So this is very important. The word keratomalacia means there is liquefaction of the cornea. Liquefaction of the cornea indicates keratomalacia. Corneal ulceration greater than 1/3 is quite dangerous because it can lead on to perforation. And when you say excess, you're talking about corneal scarring, which is the later stages, which may require surgical intervention if the scar is present in the pupillary axis. And XF is a xerophthalmic fundus. Here you have multiple white spots in the retina. These white spots in the retina should suggest to us that there is a possibility of a